Next, we have Professor Atul Kumar. He'll be talking to us on tackling recurrent or persistent DME even after a successful vitrectomy.
So,
Thank you, sir.
you've all been hearing very good lectures on diabetic macular edema, and I think just in the series of that diabetic edema can be very resistant or non-resolving, or you say chronic or relentless or recalcitrant. There's so many words they use, recalcitrant DME. So even after surgery, sometimes the conditions don't improve, the patient's morphology as well as the vision does not improve. So classically speaking, for persistent DME, what do we do? It's best to switch after 3 to 5 injections to another injection if you feel so. And of course, besides all this is the control of metabolic control and also laser, because with the wide field, even with a Heidelberg, you can get about 102-degree field with the patient moving right, left, up and down, so you can get over 100 degrees, which is wide field, and therefore peripheral retinal ischemia can play a role in diabetic macular edema. So we don't treat the peripheral retinal ischemia in the periphery anterior to the equator. You will end up with DME, which is thought to be due to VEGF release, but it's not the VEGF release from the center. It's basically, it's correct, it's better to release from the periphery. So all those lipid control, the hypertension control, as ACCORD study says, is very important. So the second is combination therapy. We already heard Rajiv Raman on that, and protocol U showed us very clearly that there was no role of combination therapy, and RBZ with ranibizumab with sham did as good as ranibizumab with Ozurdex. So no significant improvement in vision, but there was improvement in the morphology in the central macular thickness. You can do rescue laser, and laser always plays a big role in DME, though it's not supposed to be done in the center, but it can be done in the paracentral area where you can do focal laser. Or in the periphery, we can do a peripheral targeted laser based on the fluorescein. The fluorescein tells you where the capillary non-perfusion areas are. You can do rescue laser. So this is a very old study from the diabetic retinopathic network, and this drca.net has published a number of studies, one of which was led by Julia Haller, and they showed that for tractional DME there was significant reduction in the retinal thickening, and the visual acuity improved by 10 letters in 38% eyes. But also there was a decrease of vision of 10 letters, which is ETDRS vision. The ETDR is always in letters as compared to Snellen's vision, which is in lines. So it's more a 22% reduction in the vision in letters. So there was not a very significant improvement on when it comes to vision. So what is the role of PPV in recalcitrant DME first, before talking about recalcitrant DME after vitrectomy? It relieves the traction, and it shouldn't be done, probably I think it should not be done in non-tractional DME until and otherwise you've given up everything, which actually rarely happens. So only if you got tractional DME, and tractional DME does happen. There's some kind of abnormal hyaloid I've seen. This vitreous gets adhered to the fovea. You get a lot of VMT and ERM formation. Probably the laser also and all the inflammation setup leads to epiretinal membrane formation. When you see these ERMs, you first try the anti-VEGF. If the anti-VEGF doesn't get relieved, then of course you should counsel the patient that you need to get a epiretinal membrane peeling, because you show him the serial OCTs. Serial OCTs, you show him that the DME is not going down the way it should, and it's probably the ERM which is causing the vertical traction, and this leads to the cyst becoming very vertical. So that's an indication that you may need to do, and also look at the morphology, the ellipsoid band, and also the kind of neuroretinal degeneration setting in, the drill setting in, all that setting in. Maybe you can discuss with the patient. It's always important to talk to the patient, because his vision may not still improve, and he may be on you after the surgery that what have I achieved. So everybody wants vision and the patient angle. They don't understand what all is drill and all that stuff. So it's important. But of course, by removing the ERM, and also if suppose you're removing the scaffold, then you increase the delivery of oxygen to the retina. This has been shown in previous studies, and also the inflammatory mediators of DME like VEGF. But VEGF is not the only mediator. There are a lot of other anti-angiogenic mediators. There's a limited role of vitrectomy in cases where there's discontinuity of the ellipsoid. So please look at the outer bands. If there's a ELM ellipsoid band discontinuity, I would rather say that we shouldn't go in for surgery and keep the treatment conservative. and inform the patient about the final visual outcome. And probably he won't attain very good vision. Give him best correction visual glasses, give him some low vision aids. All that plays a role. And submacular exudates is a harbinger of poor guarded prognosis, and usually no, of course, no surgery, of course. And you may try steroids, because steroids work somehow in submacular exudates. You can try triamcinolone, or usually patients can afford Ozurdex if they can. If they can afford the 700 microgram pellet for 3 months, it may help to some extent, but not totally. He's not going to get 6/6 vision or something, but he'll probably end up with some improvement in his vision, will carry out his daily activities and all that. That's what they need. So you've got to discuss it with the relatives and the patient. Also look for other changes. This is a patient who had a DME. Sometimes post vitrectomy there's a little inflammation in the membranes form. So in the first surgery, if you've not done the DME, the taking care of the macula carefully, then these membranes form. The thin, thickened, translucent membrane is formed. So peel it across. The mild bleeding, you don't worry about bleeders so much. They generally stop. They don't. You just identify the bleeder and make sure that you don't take the pressure to 60 for too long. And here you can see that the OCT shows, as just talking, there's a IOCT. I use the IOCT with it. So the IOCT shows me that there's a very thin fovea. So I'm not going to peel across the fovea. So what I do is I peel the ILM across the center from the paracentral area and leave the ILM in the center, like as if I'm doing it for a hole. So I've left the ILM in the center bunched up, because I'm not going to peel the ILM in the center. You see the foveas, because of cystic macula, it's a very thin fovea, atrophic fovea. I'll create a hole, definitely. If not now, it will be post-surgery. So it's best to bring the ILM in the center and leave it there, and then check the IOCT, because the intraoperative OCT gives you a lot of information about the status, and you be sure about that you've not created a iatrogenic break, and leave gas at the end of the surgery, and probably SF6 will be insufficient. That's what I usually do. And add on some laser in the periphery. Sometimes, so this is a patient, is a post-vitrectomy recalcitrant. So many of these cysts actually are ORTs, and they are photoreceptor degeneration, and this is a sign of neuroretinal degeneration. Neuroretinal degeneration is never cured by anti-VEGFs. So there's some degree of drill. This is a fovea. So there's loss of inner segments, and also a serous detachment. And there's of course, the ellipsoid band is somewhat continuous, but there's a lot of fibrin there, and all that stuff. And the retina is extremely thickened. These patients don't have a very good prognosis. You can keep on injecting, but some recalcitrant DME. This is another patient who had his vitrectomy, and he came back. So the macula was not tackled by somebody, and so we had a little bit of traction still there, and probably a very thin fovea. So these kind of patients, you'll probably go back in and do the surgery and make sure you remove this fibrous ERM, and because there's no other option without surgery. And if you do any anti-VEGF, it might even worsen him. So you go back and do it very carefully. Probably spare the center if you can, or just trim the edges as was talked, and don't tackle this area, and remove the traction from the surrounding areas, not from the center, peripapillary area. So this is a diabetic patient. So, but he had a VMT. So I just did it recently. I just want to show you how we tackle VMTs, and this is done on the Ingenuity. I use the 3D visualization system, and the 3D visualization, of course, no DR, but there's patient had diabetic retinopathy, he had a VMT, and so show you the VMT. This is the wave of the hyaloid, which is lifted up as you do, and that's the first surgery. And this puts some brilliant blue G dye, and I like to stabilize these retinas with VMT and all, with little bit of perfluorocarbon bubble, small bubble, and put some additional BBG under it to stain it. So you can see the traction will be visible to you soon. Yeah, it just comes and goes, because see the retina is lifted up from the region where there's a traction. So the IOCT guided you make sure that the security which you have is that you're sure that you're not created a break. So the IOCT really provides you that on the table itself you see the retina settling back. If the retina settles back, you're satisfied that you've not created a break, you've got the retina settled back. You aspirate the PFCL, which is never left behind, replace it with air gas. So the issues that there's chance of ERM formation, comorbidities, inflammatory mediators, in vitrectomized eyes, the pharmacokinetics changes. So the issues are that there's an increased clearance of drugs. So anti-VEGFs will, though the dose is the same, but there's increased clearance. The dose does not vary. Only in silicon-filled eyes, half the dose is injected. But in gas-filled eyes, same dose of the anti-VEGF injected. If you're injecting 0.23 ml of Lucentis or Accentrix, same will be injected. But in case you're injecting the silicon-filled diabetic eye with DME or for giving an anti-VEGF, you have to, finishing. So this is the last slide, and there's a role of intravitreal steroids in vitrectomized eyes because of the increased clearance of anti-VEGF. So the rationale of using anti-VEGF. Now there's also a lot of work on fluocinolone implant, and FDA has given it approval. And just recently I was reading 10 days back, the Paladin study which has come. It's a 3-year safety and efficacy profile of 0.19 ml fluocinolone implant for DME. It's by Singer et al. And AIOC2022. You can refer to this, and you can see that the fluocinolone did improve the final efficacy and was safe. They said very positive results. So many of these studies are industry driven. So you have to kind of weigh it with the options you have, because there's a secondary glaucoma, you might need trabeculectomy, you might need some valve surgery, so all that. So please don't go blindly into these studies, but this is a very recent study. Thank you very much.
Dr. Atul Kumar, I think he's shown us how not only to manage tractional DME with surgery, but also how to handle post-operative